Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am back in the Sunflower House for another edition of Speaking of Women's Health. And I have a recurring guest who was just so fabulous on the last podcast on physical therapy. It's Vince Whalen. And let me remind you about him. He's a seasoned physical therapist that has a wealth of information. And in the last podcast, we talked all about vestibular testing, aging shoulders, balance, activating the glutes, trying to stay out of a nursing home. So if you missed that podcast, you have to go back and listen to it. So whether you're recovering from surgery or dealing with chronic pain like so many of our patients, or navigating female issues like postpartum changes, midlife women's health, physical therapy's really been a game changer. It certainly has been for me and my family members and so many of my patients. But before we dive into part 2 of physical therapy with Vince Whalen, let me tell you a little bit about him. He is the co-founder of Wadsworth Family Physical Therapy with Kathleen Whalen. He attended and graduated physical therapy school at Columbia University, and then he returned to get his doctorate in physical therapy from Regis University. He is McKenzie certified for over 3 decades. And I've done a previous podcast on back pain and sciatica and a little bit about the McKenzie method. Not that I am an expert, but 80% of us have back pain at some point in our life. And when my brother was having trouble, he's a big time barefoot water skier and competitor and weightlifter. It's like my siblings, they really outclass me in terms of physical activity. But he was having problems, so I did that. And really, everyone should have an awareness of that. Vince instructs physical therapy students. He pays it forward. He's also authored a book, and he's an expert in dizziness and vertigo. So welcome back, Vince. Thanks so much for joining us again.
Great to be here again.
And in the last podcast, you told us about the services that your large team provides, and how people can access physical therapy directly or through referral. What I want to do on this episode is talk some specific things about women's health and some of the issues that you deal with in women. And I remember you previously mentioning things about the female knee, and obviously women have a lot of muscle imbalance, a lot of ACL issues. Sometimes it can be menstrually related, or they might be more at risk for injuries. So tell us about the female knee.
Yeah, so ACL is absolutely an epidemic. And, I played soccer my whole life. So now the guys that tore their ACLs in our 20s and 30s, now they're my total knee patients in our 60s. Oh. And we really need to break this cycle. But there is a program called FIFA Plus that was developed in part by Holly Granelli. And it was developed for soccer players. And it's a 20-minute program, 2 or 3 days a week. It was found to decrease ACL tears 50% in female soccer players. It's been around for a quarter of a century, and we really need to get that word out. So it's FIFA Plus is the program, and it's basically looking at how the athlete moves and strengthening their hip muscles, working on their balance, working on really the mechanics, avoiding the positions that tear ACLs. A lot of these ACLs are just non-contact tears. And so that's one thing I really want to emphasize is that prevention, if we can get our coaches to kind of integrate this program more readily into the high school athlete, I think would really help cut the risks. So we know, the hormones play a role, the pelvis changing plays a role in females. Maybe males are more active a little bit. Maybe males are in the gym a little bit longer. But the fact that this program cut the risk for ACLs 50% tells us how important movement patterns and strengthening are to prevent these horrific injuries. Because, they take a high school girl and they throw them out of their sport. They lose their social connection. It's really almost always a year to get them fully back to their sport. And we see way too many ACLs in our office still.
My older son's girlfriend in high school, who was like a really top volleyball player, it really took her out and she had to have surgery. And so I remember kind of reading about that. And is it frequently that their quads are stronger than their hamstrings? And so that puts some tension on things, or?
There's definitely muscle imbalance is the problem. You know, the hamstring does the same thing as the ACL. It keeps the tibia from sliding forward. So strong hamstrings are important, but it kind of gets back into the weak glutes again, where the femur is rotating in and then the knee is not lined up for a lot of the activity. You know, how someone lands for a basketball player. If you land with bad mechanics, no matter how strong you are, it doesn't really matter. You're putting abnormal force on your joint there. And in the ACL, you know, in women, it runs a little different. It's a little thinner. But, you know, it's a problem in men as well. So I think really looking at having these coaches really watch and learn about mechanics. You know, we've done this big push for concussion. And I think now we need to have this big push for the lower extremity injuries in terms of training our coaches.
And what is there anything new in patellofemoral syndrome? I know that's another issue that young girls tend to have issues with.
Right. It's kind of the same movements that get the ACL. You know, your kneecap is supposed to track in a groove. And when the femur rotates too much, then the kneecap tracks laterally. And we start seeing that really in the kids in late grade school because their bones have grown so much, but their muscles can't keep up. You know, it was always the model in PT was strengthen the quad, strengthen the quad, strengthen the quad. And I think I mentioned last podcast, my friend Chris Powers at USC has done all this work on patellofemoral. That's his whole career, and really showing how important glute max, glute medius are. And we really just need to really make sure we're training those in our young athletes, because when they're weak, that throws the lower mechanics into a bad position and sets it up for ACLs and kneecap issues.
Well, I'm so glad I'm learning about this because I just found out I'm expecting my fourth granddaughter. And so I can just tell, just based on their fathers always were very, very athletic, and their mothers are too. So I think I'm going to have some tall female athletes in my family. So that will be good information. So one of the other issues, of course, that a lot of female athletes get into, depending on their sports, is like the female triad syndrome, where they lose too much body fat and they stop their menstrual cycle, so then they don't mineralize their bones. And I think some sports are worse than that than others, like ballet and gymnastics, or in wrestling. That was the one sport my kids didn't do. I was glad, like trying to make weight, like anything that's too negative about the body weight, I don't really like. So I imagine as a physical therapist, you must interface with some of those issues.
Yes. We always keep, the eating disorders is certainly still a big problem with our high school kids. So I think we're really concerned and keep an eye on that. And, for those problems, we obviously contact their family doctor and get them involved to help us with the nutrition end. But yeah, this, our Facebook society is certainly not easy on anyone's self-esteem, I think.
Mm-hmm. Yeah, that is true. And I think encouraging people at all ages to be physically active, it's good for cognition, it's good for the mood, it's good for socialization, for so many things. Moving into the pregnancy realm, like I often said, I wish I would have gone for physical therapy for just gait and pelvis and strengthening. I had to go after postpartum because of neck pain from breastfeeding, and I really got so improved by that. So you want to tell us about some of the pregnancy or postpartum type services or issues that you see females getting into?
Yeah, so our pelvic therapists are big fans of getting women in before delivery to show them how to stretch and strengthen up their muscles to help them through, and kind of educating them on how things are going to be post-op or post-delivery, hopefully not post-op, what to strengthen, what to stretch, and then post-op or for post-op after a cesarean section. Sorry, C-section. Yes, after a C-section. You can tell this is not my area. Then obviously they're working the scars and trying to teach them how to get the abdominal muscles strengthened up again. The SI joint is, 70% more common in females, and with pregnancy, a lot of times during pregnancy, the SI joint is very painful as the body changes. So a lot of times they're using maternity SI belts to help support that. They find that helpful. And then after birth, there's often a lot of SI joint work and teaching them how to strengthen everything back up so that they, don't have issues. So many women, as we're talking to them, my back started hurting after delivery, and until we had our pelvic health program, really they just lived with it for years and years because a lot of it was SI joint pain that was never addressed.
Yeah, that is just terrible. And also diastasis recti, because of course the expanding baby. Some women have twins, even triplets. It just like pulls that muscle apart. So I imagine like some sort of modified sit-ups to strengthen the abs to kind of get that back in shape.
Yeah, that deep transverse abdominis is that's your deep abdominal muscles. A lot of times when you're doing crunches and sit-ups, you're really just pulling that abdominal wall apart. The pelvic therapists really work on trying to get that deep abdominal muscle to strengthen up to prevent that from getting worse. And often they do very well and they tighten back up.
Now, another problem that women have with aging and also pregnancy and trauma to the pelvic floor, of course, is stress urinary incontinence. Like I'm always telling women, well, when you have a vagina, that's a hole in your pelvic floor, so you don't have as much support for the bladder neck. And obviously there's gravity, there's aging, weight gain, pregnancy, trauma can all affect that. And then there's genetic factors, I think, that affect other connective tissue support. So a lot of women think it's normal to leak when they cough or sneeze, which of course it's not normal. And if they're doing physical activity like running or jumping, that puts more stress on the pelvic floor. So do you want to talk about some of the pelvic floor services that your team offers?
Yeah, talking to our pelvic floor therapists, they said really there's kind of two big categories of pelvic floor problems. One is there's too much tone, too much tightness.
Yes.
And then the other ones don't have enough tone and not enough tightness. So the people that have too much tone, doing Kegels is only going to feed into the problem and make it worse. They're good for the people with low tone. So you really got to figure out, your body to urinate and to perform, it has to be able to relax some muscles in order for that to happen. So they really feel like most of their patients have too much tone in their pelvic floor. So they're working on techniques to try to decrease that tone. A lot of times the hip flexors are tight. If they've had any abdominal scarring, even up higher, can tighten things down low. Stretching their hips becomes pretty important. So it's pretty important that you get evaluated before you, I think, just start randomly doing Kegel exercises.
That's a great point, I think. And one thing that I tell my patients, and I have some terrific nurse practitioners, APPs in my practice who help me, by doing routine exams so that I can do the consults. But when I do a pelvic exam, and how I taught the nurse practitioners, and I tell my patients, wherever you're getting your routine gynecologic care, the person who's doing your full pelvic exam shouldn't just be vaginal. You also need rectal because you need to feel that whole pelvic floor. Should assess to know if you even know how to do a Kegel correctly, because I would say about 10 to even up to 20% of women don't even know how to activate their pelvic floor. Those are the muscles that contract with climax. Those are the muscles that either contract to stop urination or relax. And some people just aren't wired to know how to do that, though they may be very, very athletic. On the other hand, a lot of women, because of trauma or endometriosis or surgery or sexual assault, falling on a bike as a young child, pelvic fractures, a lot of different things that can happen, can have a lot of tenseness, a lot of muscle spasm. And like you said, that can even affect the gait, the bowel function, the bladder function, and certainly a vexing problem that some women, deal with. And I didn't realize it was that difficult until I was reading a chronic pelvic pain book that one of my colleagues had recommended, that a pretty decent percent of women post-delivery have chronic pelvic pain. And so you want to talk a little bit about how someone can find a physical therapist that's trained in the female pelvis and what some of those caveats are?
Yeah, I think if you go there's definitely a women's health section in the American Physical Therapy Association. So you can go to their website and find therapists that do women's health. It's definitely a very unique specialty. There's a lot of things we can all do, but definitely the pelvic floor patients, we have two therapists that do that, and those are only two that have the skill. So it's important you find someone that does that. And both of our pelvic floor therapists wanted me to emphasize that internal exams often keep people from coming to therapy because they're afraid of how painful it's going to be, how awkward it is. And they just wanted me to really reassure everyone that if that they can still get better without having that done. And we can start with some exercises, and a lot of people never even need to have that done to them if they're not comfortable, can still get benefit. So that was one of the big emphasis. So I think you just got to really find, this is not something that just a random therapist can do. You got to find someone who actually has advanced training, because it's really not taught in schools. It's just touched over, but the instruction is really postgraduate for the pelvic exams.
So upper level. So you have been listening to the Speaking of Women's Health podcast, and I am your host, Dr. Holly Thacker, in the Sunflower House with a recurrent guest, physical therapist Vince Whalen. And we've talked about female athlete triad, knee problems in young athletes, the importance of the glutes. We've kind of moved into the pregnancy, postpartum realm, chronic pelvic pain. We had a prior podcast with minimally invasive surgeon and chronic pelvic pain specialist, Dr. Ashley Goobel. So if there's any listeners that have dealt with chronic pelvic pain and pudendal neuralgia, endometriosis, that's a good podcast to go back to listen to. And I hope to have her back again on our podcast. I would say that one of the points that she made, because she sees patients come from all over the country and all over to see her, and in a lot of rural areas or underserved areas, there's not a good pelvic physical therapist. So, what do you do? Do you have patients come from far away for an initial assessment, and then can your therapist communicate with a general therapist? Are there ways to give them the program that they can do, or is there any remote access or virtual physical therapy, I'm wondering?
Yes, actually, remote physical therapy is covered still.
Oh,
and so usually the evaluation needs to be done at least in person, but then after that, a lot of the coaching can be done remotely for sure. But there is definitely a tremendous need for pelvic health. And men have these issues also after prostate and
yes.
So in that area is super underserved. There's hardly any men doing this, which is something our profession, I think, really needs to work on. A lot of men would be more comfortable going to another male.
Absolutely. Yeah, I know that the clinic only has one male physical therapist in the whole system here in Northeast Ohio who's trained in the male pelvis. But obviously with, I would think, radical prostatectomies or trauma or excessive, bicycling, can obviously injure the pudendal nerve, which comes out in a number of different areas. Do your physical therapists use TENS units or biofeedback to try to help teach the person how to control some of these muscles that aren't fully under conscious control?
Yep, they do. They use biofeedback, and I don't think as much TENS units, but definitely biofeedback is a pretty big part of what they do, especially with patients that have too much tone.
Now, I know with certain chronic pelvic pain, Dr. Goobels was talking about trying to figure out is it pelvis from inside the pelvis, or is it actually back related, and how, I don't know if there's some AI that people look at. Do you have any comments about patients using AI to try to figure out what their musculoskeletal problem is? I'm curious.
AI is, we had Dr. Google before, now we have Dr. AI. Dr. AI is definitely better than Dr. Google. So, I think an educated patient is a great thing. And then if they bring that to us and we talk about it and share it, I think it's been overall a good thing so far. With the pelvic floor, the referral patterns, the higher lumbar nerves refer into the pelvis, like L1, goes into the groin. T12 goes just above that area. The hip refers to the groins. A lot of the people that are pelvic floor really are referred pain from the spine or from the hip. So a lot of times the patient will call saying, well, I'm having this groin pain. Well, it really turns out they have a really bad hip or they have a lumbar issue. All that has to kind of get sorted out. And obviously a stiff hip, is a problem with sexual function for a lot of women. An arthritic hip can get in the way. So sometimes the biggest thing we're doing is really identifying what their pain generator is and then getting them on the right path.
Excellent. Now, I think we should probably move into chronic back pain and Mackenzie in one of your areas of expertise. Tell us, what is the Mackenzie method? Should everybody know about it, or just people that have back problems?
So Mackenzie started this system in 1956 in New Zealand for the lumbar spine. He kind of switched the paradigm from physical therapy. Originally, everything was a muscle, so treatment was really heat, massage, stim was really the cornerstone of what we did. He got to start thinking about the discs and the joints and really looking how different movements and postures impacted pain. So he took this idea and had people do repeated movements, repeated static postures, and see if they could figure out where the problem was coming from, and from there, how to treat it. And from there, most importantly, which is the great thing about Mackenzie, is how to prevent it and how to deal with future episodes. So it's a really empowering system. So often, we could go in and, do a manual skill to fix the patient, but then they're really not learning how to take care of their spine. So really, the initial visit for Mackenzie is really trying to teach them the movements to get their pain under control. In most cases, we're not laying hands on the first day. At some points, we do to help them get over the hump. But that's really the genius of Mackenzie, is teaching you why you got here. Are you sitting wrong in your car? Are you lifting wrong? What's really causing your pain is the cornerstone. And then from there, the treatment is pretty obvious. And then a lot of people just need a little bit of maintenance. A lot of our people, with disc bulge and stuff, they need to take care of their backs like they take care of their teeth, and do a little bit of stretching in the morning and the evenings, and then they do very well. Or if they know they've been on a long car ride, they got to counteract that with some stretching. So now the system's in 40 countries, and we use it on the neck and the extremities, the SI joint. So it's really a whole body approach now to physical therapy.
Boy, that is really fascinating. And for people who don't have any back or neck problems, although I'm sure a lot of people are going to everybody's always down looking at their stupid phone all the time. Should people be proactive because chronic back pain is such a problem, like in terms of doing work to stabilize those core muscles? Because a lot of people have weak muscles and don't even know it, right?
Right. Core strengthening is obviously really important for prevention. Mackenzie, interesting, is really not that big on strengthening, but it was developed really with a blue-collar population in New Zealand. So, these people were lifting. It's our American, modern-day system is a little different that way, where that's one of the weaknesses of Mackenzie. It's not really a big emphasis on core strengthening at all, but a really big emphasis on static posture. He thinks really overall, the theory is that all this rounded forward head posture is what's getting most of us in trouble, that we were never designed to be sitting like this. And obviously we're sitting even more now than when he first developed the system. So yes, static posture is one of his big cornerstones of treatment. So trying to have a little bit of an arch in your back, your chest up and your chin in is a really important part of the Mackenzie system. For most people. As you get the older population, they start getting into stenosis. Then we kind of actually tell them to round up a little bit and walk a little flex. It works once you get into the later years and stenosis becomes a problem, that narrowing of the spine, then we switch paradigms a little bit on that.
Interesting. Yeah, that certainly can be a problem. I have some patients with cervical myelopathy, and if they have a lot of arthritis at the upper part of their spine, that controls the whole rest of their body and balance. And I know in the last podcast we talked about assessing for balance or dynamically improving people's vestibular system to reduce falling. So as you know, I love golf, and so I gotta get ready. I gotta get ready for the golf season. So, are there any specific things I should or shouldn't be doing to kind of get that spinal flexibility and get that swing going?
Certainly strengthening the core and lower body is really important. In golf, it's no one golfs both-handed. Everyone has either right or left-handed golfer. So if you think about it, if you're a right-handed golfer, you're always twisting left. So over time, you're probably going to need some work stretching the other direction.
Okay.
So trunk rotation is really important to keep that symmetrical. So one of our therapists, Ben Romansky, really wants to be a pro golfing instructor, and he's really into it. But he really has them flex over in the golf position and really sees how well they rotate, and almost invariably they're blocked the opposite way that they swing. So kind of for prevention, going the other direction. It's also a lot of force on your knees. Your inner thigh muscles are really important for golf. Actually, that's the one sport as you transfer your weight. So your adductors. So getting those strong is really helpful. And then, those golf carts I always go back to. But, I always go with my kids and they bounce me around like nothing. So trying to keep your posture good on the golf cart, I think, is really important. And probably the less you're in that thing getting bounced around, I almost think the golf cart sometimes is harder than the game, at least when I go with my kids.
My husband always complains about my driving, but of course, some of his driving, he's flung me out of the golf cart one time making a turn. Those golf carts can really be quite dangerous.
They can be. They need to get better shocks on those, I think.
And so, any other tips for any other specific kind of physical activity, like something? Any tips for swimmers or bowlers or walkers or hikers or any?
Like in terms of lower extremities, the hip flexors are almost always what is getting tight on us. Those are the muscles in front of your thighs. So trying to stretch those out. Almost anyone who's doing any lower extremity activities, biking, anything that's rounding, your hip flexors, unless you have a job where you're standing and leaning backwards, get tight. So stretching your hip flexors, I think, is probably the biggest muscle that we stretch for sure. And then for your shoulders, we talked about the rotation, strengthening that up, and then making sure you keep your shoulder mobility in all directions. People kind of forget about reaching across the front of them. For golfers, they often get tight this way. Tennis players get tight there. We actually do see a lot of tennis players. And I think when you're doing your strengthening, the shoulder is not designed to work when you're rounded up. So when you're doing your workouts with your shoulders, mechanically get your chest up and really make sure that that automatically puts your shoulders in a good position. So you're strengthening it in the way it's designed to move. So any upper extremity strengthening, that becomes super important. And then I think, go ahead.
No, go ahead.
I was going to say, if you're doing a lot of rounding, a lot of abs, then most people then need to follow that with a little bit of backward stretching. So we have a lot of people, in January, they start working out, they're doing 1 million crunches, and now that's hard on the disc. So if you follow that with a little bit of backwards stretching, that would really, really help you out, I think.
So important. There's so many areas to work on and balance. I do tell my patients that I think the older they get, it's important to stretch before and after exercise. Would you endorse that?
I agree. Yes.
That is something. And any final thoughts? How people can contact you, contact your staff? Is there any social media or any resources that you think it would be good for our listeners to know about?
We do, yeah. If you type in Wadzo Family Physical Therapy, we do have a website that gives us all the contact information. Depending on what's wrong with you, each one of our therapists is an athletic trainer, so we kind of try to steer you into someone who is skilled in what your problem is. Everyone can all do the basic things, but we see a lot of failed therapies, so then we try to get those people onto the therapist that has extra skill in that area.
That's very helpful. And any comments about, I know that there's a lot of Instagram influencers that, put out all these little, do this, do this exercise or do this or do that. Any comments about that?
I think some of that stuff is interesting to watch. And some of it's entertaining, some of it's quite good, and then some it's not. But I think, overall, the person has their doctor in physical therapy, that I think a lot of those people have a lot of good suggestions and a lot of good ideas.
Mm-hmm. Yeah, a lot of interesting YouTube channels and orthopedic channels that I found. So I think you were telling me about shoulder replacements in terms of like rotator cuff tears, that they're getting better, so people are going to that faster. Did I hear that right? Yes.
Yeah, the rotator cuff for those big tears are in slings, 6 and 8 weeks, and then they can only move it a little bit, and it's a very, very long process. The total shoulders, for those people that are kind of borderline, they're getting active much faster. They cut one tendon in the subscapularis. We have to protect that for about 4 to 6 weeks, and then people are getting active much quicker. They really got that down. They did that reversal of the ball and socket when they put the shoulder replacement in. If you're 20, obviously it's not the idea, but a lot of the patients in the 60s, we're not going to live forever. How much time do you want to spend on the shoulder? And really, the old design of the total shoulder, all we were trying to do is relieve pain. The new design, really, we're getting their function back to normal. So at the end of the day, there's not a big difference between the total shoulder and the rotator cuff repair in terms of what they can do.
So fascinating. Well, thank you so much for joining us, and thanks to our listeners for joining us. Please give us a 5-star rating. If you don't already subscribe, you can follow us on Spotify, Apple Podcasts, Amazon Music, wherever you listen to podcasts. Forward it to friends. If there's any other topics you want us to cover, let us know. You can email us on speakingofwomenshealth.com under the Contact Us portion. And we'll be back next week with another episode. Until then, remember, be strong, be healthy, and be in charge.